Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello, everyone, and welcome to another special COVID edition of our Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to have the opportunity to be present in this territory. Today, we are delighted to welcome Children's Healthcare Canada members, BC Children's Hospital, Holland Bloorview, and today's sponsor, ChildBright, for More Than Medical, supporting NICU families with their transition home during a pandemic. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and we'll pose the questions to our panel at the end of the session. I'd like to introduce our speakers today. Dr. Paige Church is an associate professor in the Department of Pediatrics at the University of Toronto. She is on staff at Sunnybrook Health Sciences Center as a staff neonatologist and is a consulting developmental pediatrician at Bloorview Kids Rehab. She's also the director of the Neonatal Follow-Up Clinic at Sunnybrook Health Sciences Center and the co-principal investigator of the ChildBright Network Coached, Coordinated, Enhanced Neonatal Transition Study. Amin Nowak has lived in BC her entire life and started working at the BC Children's Hospital early in her nursing career. And she's been a pediatric general surgery nurse specializing ostomies and wounds since 2006. And Kate Robson is the parent partner lead at the Coached, Coordinated, Enhanced Neonatal Transition Research Project. Both of Kate's daughters were born preterm. One was a 500-gram, 25-weeker born in 2005, and the other came at 32 weeks in 2007. Inspired by her own experiences, Kate came back to the NICU in 2010 to work with families as a neonatal intensive care unit family support specialist. And she has a private therapy practice in Toronto where she offers support to NICU parents and clinicians. It's my pleasure to pass the mic to Dr. Church.
Thank you very much. So our learning objectives, today are going to be to talk about the challenges experienced by families during and after their transition to home who leave the NICU. We're going to discuss how COVID-19 has exacerbated these challenges and created new ones for our families. And then we're going to describe how supportive and holistic care models, such as the approach we've been using in the CCENT trial, acceptance commitment training, can help families address these emotional stressors and come up with practical and emotional solutions for the issues they're experiencing. Next slide, please. So what I'm going to do is talk about mainly the experience leading up to discharge, and then I'll hand it off. Next slide, please. So this is a great diagram that was created by Kate Robson, who's here with us today, and Virginia McLaughlin in 2018. And it really demonstrates in the NICU sort of we call it the spaghetti diagram of trauma and stress in the ICU. And I love this quote from Dr. Heinen, distress is the companion of everyone in the NICU. What I will argue, however, is that while we think transition to home is a celebratory event, and in some ways it is, I think it's also a transitional moment where there is the potential for significant trauma and distress. Next slide, please. So using that same spaghetti diagram, when we start talking about transition to home, the issues are still very much the same, particularly with COVID. So while they're home, there's still the sense of isolation. And now with COVID, it's gotten even worse with separation from friends and family as we talk about bubbles and limiting our bubbles. There's the psychological isolation of having a unique baby at home that nobody else can sort of identify with or share with. And then there's the physical and the social isolation that comes with being bubbled during COVID. Next slide, please. There's also a sense of lack of control, and this continues even after these babies go home. And it is in the sense that these babies don't necessarily follow a schedule, and they rarely do. So feeding, sleeping are really issues that you can't necessarily control. In the ICU, we can make it look so easy. Every 2 hours, every 3 hours, a baby feeds X number of cc's. And then the baby goes home and the baby isn't following that strict schedule, isn't following that volume of feeds, and that can be a source of great stress for the families. There's also a lack of control as you're introduced to new care team members, public health nurses, early intervention, and these things through COVID are happening to some degree or to some degree less. But you know, it is a whole new care team, and sometimes not a care team that they have control over who they are assigned to. A new pediatrician, new family doctor, all of it. New slide, please. And then there's the onset of fatigue. You know, these parents are tired. Babies aren't necessarily sleeping when they need them to. They're being asked to do more that they weren't doing before. And that can all lead to incredible fatigue. Next slide, please. And then there's pre-existing challenges that existed even before their baby was in the ICU, and they don't necessarily get better or easier, and that can be socioeconomic. Paying for parking to go see different doctors, that can be a stressor. Relationship challenges may become more challenged with the stress of being isolated, being exhausted, having differing opinions about how a baby is to be cared for. And then there's systemic problems within society around prejudice and racism. These things don't necessarily go away because now you have a beautiful little baby in your arms. And then mental health and chronic health conditions. Neither of these is bettered by fatigue and exhaustion or stress, and this continues even after they go home. Next slide, please. And then there's exposure to judgment in a way that perhaps families weren't expecting. There's inappropriate comments from, I mean, probably less now from strangers who don't know the situation because babies aren't really getting out of the house, but there's inappropriate comments from friends and family, things said about what a baby should or should not be doing that are ill-informed. There's a scrutiny of parenting, and we really run into this with generational input. So a mother or a grandmother may not feel that the mother's doing it the right way, even though that's the way we encourage the mother to do it in the ICU, because that's not the way she did it. But chances are her baby in the ICU wouldn't have even been able to survive because the technology didn't exist. So there's a scrutiny of parenting that's pretty intense. And then there's this sense of the parents feeling not good enough. These parents go from teams of respiratory therapists, nurses, dietitians, social workers, bedside nurses, team leaders, all of these people taking care of these little pharmacists, taking care of these infants, to then it's just boiling down to 1 or 2 people taking care of them. And often what we hear in clinic is that they feel like they're just not doing a good enough job. And we try to remind them that the team has gone from 12 to down to 2 or 1. Next slide, please. And then there's an identity crisis that still happens. You know, no parent that I know of says, gee, I would really love it to have a baby at 23 or 24 weeks and experience ICU and then transitioning to home with a medically fragile or a developmentally fragile baby. So there's still this loss of a dream, and sometimes that really becomes realized after the initial crisis and the initial goal of just seeing survival, when they take these babies home and they're more medically fragile than they envisioned, and they're going into these nurseries that they dreamt of a different reality. It becomes perhaps in some ways a bit more in their face. And there's also this identity crisis with parenting challenges. In their minds, they may not be the parent that they saw as being, and that might be compounded by the stress of everything that they're experiencing. Next slide, please. And then there's the last thing, is living with this fear and tension. So We do a great job in the ICU of talking about the potential for survival and outcomes, but what it ends up doing is it creates this fear of the unknown. And while that is something we can't avoid, for sure, we have to be transparent with what we do and do not know, and that time may tell us, that living with fear of the unknown can be really dramatic after they transition to home, compounded by, again, fatigue and stress around their sense of who they are as a parent. There might be a fear of failure. We've had parents leave and they seem so confident, and then as soon as they go home, it's like the whole house of cards falls apart, and they have no confidence in their ability to take care of their babies. Again, there's this new care team and this getting to know them, and that tension that comes with new people asking questions that have been asked 15 times. And then there's inconsistent messaging, and I think this is a really big one. Is this chronic uncertainty can be bred by inconsistent messaging. And an example may be, in the ICU, we may teach parents that we see the baby as their corrected age for their development, and that includes their feeding expectations. But then when they go out to the community, a doctor or a nurse may say that they should be fed according to their chronological age rather than their corrected age. And so that lack of consistency can make parents feel very uncertain with where is the responsible answer and where is the evidence and what should they be thinking. Next slide, please. So we've talked a lot about the transition to home and the trauma around it, because it is a bit of a traumatic event, albeit a celebratory one. There is an element of an undercurrent of significant stress and distress. When we talk about the unknown and we talk about these outcomes, once survival has been sort of checked off, we're still left with significant challenges on the horizon that may or may not affect the infant. And that includes those challenges that have been identified as being associated with a lifelong functional impairment, so cerebral palsy, or an impairment in how one controls their body and their movements, vision and hearing impairment, and cognitive impairment, or a difficulty or a disability around how one assumes new knowledge. More often, and for many children, the number of children affected by these significant lifelong disabilities is small, but more often, what we do see is that many of these children, particularly those born at the very early aspects of gestation, so 23, 24, 25, 26 weeks, is the potential for lifelong functional challenges. So challenges in how you do your day-to-day living. Next slide, please. And while they're not associated with an overt disability recognized by society, they are associated with significant challenges with how you live day to day. And they include issues around mental health. So anxiety, particularly separation anxiety, ADHD, or how you organize and regulate your brain to assume new information and organize and focus on priorities. Learning, there can be learning disabilities. Learning skills can be affected. So not necessarily your capacity, but how you learn can be affected. Language, expressive, receptive. It can also include voice expression can be affected. That's significant for how do you communicate with your peers? How do you understand what they're saying back to you? And how do you assimilate all of that in a rapid fire environment of the playground? Social communication. So how do you pick up on the vibes, the nonverbal communication that people are offering you? A roll of the eyes, a turning away. What do these things mean? This can be very challenging for these children. Peer relationships as a result can be affected, and the PREM has been referred to as the nomad in other literature that just looks at how they do at school. And then motor coordination. While many of these children may escape significant motor disability that affects how they move in terms of a neuromotor presentation, they may struggle with learning to button their coat, ride a bike, zip up their pants, which can make getting ready to go to school, undressing or dressing at the winter in Canada for sure. They may be the ones that are spending more and more time trying to do this and getting frustrated or going out with their coats wide open because they can't close them and they're too embarrassed to ask for help. So those are significant challenges. New slide, please. And so what we refer to this with in developmental peds is a behavioral phenotype, and it's a pattern of strengths and challenges for a child in social, communication, motor, learning skills. And they're not necessarily associated with an outward physical presentation, but rather a common biological presentation. And so with the PREM, we've long recognized that the biological etiology, or the reason for this presentation of these children, is the way their brains develop in the ICU. We have gotten better with our technology, but we haven't quite figured out how to completely protect a brain from injury that might be obvious or macroscopic or microscopic, meaning it affects the cells. On the left of the slide, you see two MRI images. Those are infants that were born at 32 weeks for the infant on the left, and on the right, the middle MRI, is an infant born at 23 weeks, and they are both now having an MRI at term. So at their expected due date, both babies were put through an MRI scanner, and what you can see is that the brain growth for the baby born more premature, the one on the right, is much less robust than the brain growth for the baby born closer to their due date. So there is inherent variables with how the brain grows and develops that is not being optimized in the ICU to date. And we may never develop this technology, but that is a huge challenge, is how do we have healthy brains grow? For a long time, that's been the focus of what we think about when we think about these infants in the ICU and what drives their presentation. Kate, I have this animated. I don't know if it's going to work, but we can try to click it once. Just try to click the slide once. Let's see if it works. There we go. So that's what we would say is the nature, the organic piece of the etiology of the behavioral phenotype of prematurity. On the other side, and let's click it again, is the parent side. And that's the nurturing side. We have parents come into the ICU and they're thrown into that emotional cauldron that Dr. Lantos refers to, of the experience of being a parent in the ICU. Your baby is in the isolette, separated from you by ventilators, by nurses, by a specialist, and you're terrified to touch this human. That can affect how parents grow and develop as well, and that truly affects who they are and how they tackle parenting this now different child. And so the whole package together is what ends up creating this behavioral phenotype of prematurity. It's not completely just the brain, and it's not completely just how the parents are deeply affected by the ICU. It is the combination, and in developmental peds, we refer to that as nature through nurture. So what we're trying to do is, while we can't necessarily change some of the organic difficulties with making brains grow in the ICU, we can support parents in a better way and help them deal with the stress of the ICU, and then perhaps change how they nurture their child in a more effective, more resilient way that then can help leave a stronger imprint on the brain and how it grows and develops as the children leave the ICU and transition to home. I think that's it for me.
Hi, my name's Ami. I am one of the nurse navigators for the CCENT project, which I forgot to include in my intro, so sorry. I work with them, and it has been such a great experience getting to know these families in the NICU and then helping them transition home during their first year of life. And this was going along just great, and we were having all these wonderful experiences, and then COVID hit. So we've certainly noticed a lot of impact from COVID with our families as they transition home. And I thought I would help break it down by giving some of the real life experiences that families have been reporting back to us, and then what we as nurses are worried about for our families and how this is going to impact them in the short term and in the long term. So if you wouldn't mind clicking to the next slide. So the good. So there is actually some good that families reported back, more so I would say in the initial days following the onset of COVID. Families were almost excited to feel that everyone understands now what they have to go through and why they would need to limit contact with their infants. It felt easier to isolate at the beginning when everyone else is doing it as well. And a lot of the comments back were people finally get it. They understand why we have to be so careful. People aren't coming by and just dropping in unannounced, and people aren't always reaching in to touch their infants. So they all felt that was a positive, and that sometimes partners, because they were working from home now because of COVID, it was actually a little easier to involve partners into the day-to-day care. So for two caregiver situations, both caregivers were able to interact more on a day-to-day basis with their baby. So that was good. But then that was the short slide. Now we're going to move into the bad. So one thing that families have shared repeatedly is that it's difficult to get out and they're lonely. So once the initial feeling of this wasn't so bad, people get it, they have to isolate, then the same loneliness and boredom set in for them as it did for others. And it was really quite isolating. It's very hard to meet other parents of small children when you're isolating at home. There's a lot of uncertainty. So some parents have job insecurity due to COVID and are really struggling to make ends meet. There's, all of the follow-up appointments that Dr. Church was referencing. A lot of those are happening in phone visits, occasionally Zoom visits, and that can create quite a different feel for families when they're trying to connect with caregivers and form these relationships. So whereas before they were able to get out and meet their team, now it's all happening virtually for large part. The other piece is that although it was great for them to be able to isolate their baby and keep their infant safe, it was also really challenging because then when they felt like they wanted friends and family to meet their baby, it became really hard. So they also then felt it was a negative because they couldn't introduce their infant to all the family that they wanted to. And then if they did get into a bit of a bubble with a family, it was stressful because they were worried about who that family was bringing in and what potential contacts they may have had. Some families share that it's even hard to go and get groceries because they don't want to take the baby in. And that's not always an option to leave the baby at home and you need food. So as nurses, some of my colleagues and I were reporting back on some of the things that families had mentioned. And I guess one of the big things is missing out on bonding experiences with their baby in hospital. And so for some families and some hospitals, they have quite restrictive visitor policies. I think every hospital has changed their policy on how many parents can be at the bedside, but some hospitals are only permitting one caregiver to be at the bedside. So there's instances where families are coming together. One parent would go in and spend time with the infant, and then they would swap, and the other parent would sit in the car while they're waiting. And so they're being separated that way, but then they're also missing out on the chance to bond as a family unit, which is really challenging. There's also a lack of education for families. The vast majority of hospitals have education set up in the hospital with sort of peer groups, and some are happening virtually, but I think some are just not happening, or they're happening more on a one-to-one, if at all. And so that lack of peer support from other parents in the hospital can be quite challenging. I know many NICU families connect while they're in NICU, and that's also been a challenge for families over the last 6 or 7 months. The opportunity to interact with the staff in NICU, so taking part in rounds, talking in person with neonatologists, respiratory therapists, nurses, social workers, dietitian instead of by phone. And then, of course, wearing masks and physical distancing creates not just a physical barrier, but a visual barrier between families and staff. And that can be really challenging, especially for some families who either don't speak English as their first language, and even just any other disabilities or different abilities that families have in communication. So even things like the reassuring smile, a pat on the arm, getting nice first photos with their baby because they're in masks and other people can't touch their phone. And these are all just things that don't seem big, quote unquote, in the grand scheme of things, but they can certainly have a long-term impact on how families feel they were able to connect at the very beginning. There's I would say as nurses, we're also quite concerned about isolation for families. Some families initially were worried about even taking their baby outside. And as the pandemic goes on, there may be less fear, but there's still going to be isolation. So grandparents that live out of town or out of the country, visits are difficult or impossible to arrange. And part of people that would have been their support network is now unavailable. Even just locally, trying again to create these support networks once they go home, there are or there were community health units that would have baby groups and drop-in areas, and these are often canceled now. And again, that makes it harder for families to meet other people. Some families report being nervous with their medically complex babies that require nursing support. They require the support, so they need these caregivers to come into the home, but then there's an extra level of anxiety dealing with an outsider coming into the home and dealing with the fact that these support workers, or having to deal with the fact that these support workers are not available, and then they have to do the care themselves. So that feels a bit like a no-win scenario. And then we also are concerned about just the regular things that families do. And I think that one piece is that before COVID, families were able to just sort of be at home, and they really only had to worry about adjusting with their own baby at home. And they didn't necessarily need to worry about the entire world as well, which it feels like is just an added layer that is not fair when you've already had to deal with the trauma of a prolonged NICU stay. Next slide, please. So then there is the ugly, I would call it. Some families have experienced family illness and death due to COVID in other countries. These things have always happened, but of course now there is absolutely no way for these families to go and either be with their families or have their families come to them. So they're now grieving the loss of a loved one, sometimes because of the pandemic itself, being worried for their family that are still in other countries that are in COVID hotspots, and there's nothing they can do. So there's a big sense of a loss of control, and that can be quite stressful. Some families have been counseled to limit contact with their partners just because of the nature of their partner's work. And so that can be quite stressful. I know one family has their decontamination zone when they get home, where they go into the garage and strip down, go right to the shower, and then get changed, and then we'll see their family. One caregiver that I know actually moved in with his parent to try and make sure when we went from stage 2 to stage 3 that the COVID cases didn't spike too badly, to not put his fragile infant at risk. So that was a really difficult choice for them to make, because obviously it did limit their infant's risk of getting COVID or his partner. But of course that meant that the partner was home dealing with a medically fragile infant solo with no other support, which was a huge strain on that family. A lot of families have been really upset and feel a lack of support from us as healthcare providers not seeing people in person. And that's been really difficult. So they're going home, they're trying to manage how to take care of this new baby, and now they're only able to see people virtually, which doesn't leave families feeling like they've gotten a good result from their appointment. So trying to do physio or occupational therapy virtually is really challenging. And so I had one mom saying that, her baby was on the video, and she's trying to show the physio, and the physio was saying, oh yeah, it looks like her foot's a bit turned, but maybe, try doing this. And she's like, I don't even know what I was doing. It doesn't make any sense. How am I supposed to do this? Like, I'm not the physio. I can't tell if this is right or not. And then she said, well, actually, me and every other NICU parent that I've talked to is paying out of pocket now for physio, because they can go in for private physio in person, but virtual physio for publicly funded. And she said it's really hard because you can't tell the publicly funded physio that you're seeing private physio, or your public physio will get cut off. And so I think there's just a lot of anxiety for families over, are we able to make the best choices we can for our baby and give them the best care that they deserve with all these constraints that COVID has put on us, and what's the risk benefit to everybody there. People are generally just worried about the future and what that might look like. I think that this has been a challenging time, and we've added a huge layer of stress. I think that it also shows how resilient our families are, because they are making their way through it, but it's really tricky. I think that a lot of the families where the anger comes from is sort of how the hospital stay has. I can think of there's one family where they were limited to only have one caregiver at the bedside, and that was essentially, they said the whole hospital experience has been a nightmare. And families are saying, does the hospital or the government know enough to keep us safe in the hospital? So there's, I think, a lack of clarity or trust that families are feeling. And I think that that's one thing that we probably could work on as healthcare professionals, to try and hopefully streamline that or minimize that risk for people. So thank you very much for your time. And I think, Kate, you're next, I believe.
Thank you. And I just wanted to appreciate and take a moment to reflect on what you just said, that I think for families, and this has definitely been something that I've heard from the families I've worked with over the last few months, there is that feeling of, there is some anger, and there is a feeling of betrayal, because one of the first moves that many hospitals made was to push out the family in some way. And we can understand that to a degree, because we're dealing with this really unknown beast of a pandemic. But they're also, we have to take time to kind of reckon with these feelings of rage and betrayal. And I'm, as we see numbers rising across the country, my hope is that we do not exclude families again. I think we realize it doesn't necessarily keep us safer. I don't think any cases have been associated with parents in the NICU, and it does so much harm to the babies and so much harm to the families. So I just really appreciate you for bringing that in. And I want to turn now to talk about what we can do, because what we've talked about so many really big, heavy, uncomfortable, and painful things that are happening and that people are living through. And one of the things about the acceptance and commitment therapy framework that we're using in CCENT is that the goal is not to try and get rid of or to solve difficult things. It's not to get rid of our pain. It's to figure out, how do we acknowledge it? How do we name it? How do we understand what how it's making us think and behave? And how do we, carrying the pain, step forward with meaningful actions towards something that's important to us? For me personally, as an NICU parent, this model really resonated, because there were, when I was in the hospital with my baby, I didn't have to deal with COVID, but I did have to deal with a lot of things being out of my control. I did have to deal with a very precarious future. I did have to deal with so much fear and worry. And to pretend that it wasn't there, or to try and reframe it and call it something else, it felt impossible to me. But what does feel possible is to accept it, to notice it, to name it, and then to take a deep breath and to choose something to do that feels important. So to be able to take action, and to be able to take action in a moment when you feel utterly shut down and stuck in every other way, it can be an incredibly empowering experience. So that has been what we've been trying to do with the acceptance and commitment therapy part, or as we call it, acceptance and commitment training within the context of our study. That's one of the arms of CCENT that's been an incredible part to be involved with. And one of the tools that we use when we're working with parents, so we've been doing it virtually for a while, so over the phone or over Zoom, using this, the ACT matrix, which really is, it's a way of developing a shared vocabulary with families, focusing first on values, who and what matters to you most, who do you want to be, what kind of qualities do you want to show up in your life? And then we move into what's getting in the way. We move into talking about pain and memories and physical sensations. Physical sensations are a really important thing to talk about because our bodies can sometimes be like the canaries in the coal mine. So we don't necessarily have a cognitive understanding of what's going on with us, but we're noticing that we're waking up every morning with a very sore jaw and that we're clenching our teeth in the middle of the night, let's say. And so we spend a lot of time with families, with parents, just sort of being in this space and just what's coming up for you when you're feeling disconnected from what's important to you. Are you feeling guilt? Are you feeling shame? Are you feeling fear? And those, of course, are the feelings that come up, I mean, for all of us, but I think you can imagine that they definitely come up for NICU families. There's so much guilt, shame, and fear at being stuck in the hospital, being so worried about your baby, feeling all those feelings of, you know, I did this, I wasn't able to carry the pregnancy to term, I can't be there enough, other people are taking care of my baby and not me, and all the pain that's associated with that. And what we do with this model is we give that pain some light and some air, and we give people a chance to talk about it. We don't try and talk them out of it. We don't try and tell them why they shouldn't feel that way. We just give them space to explore it and to talk about why it matters so much to them. And then we move into the third quadrant where we talk about what people do to distract themselves, or what we do to distract ourselves, because we all do it. How do we distract ourselves from pain? And so this is the core. So everything, you know, under the line, that is stuff that is private to individuals. And so I wouldn't know what's important to you, and I wouldn't know what you're feeling unless you tell me. The stuff above the line, that's what the world sees. And so if I were feeling really guilty, what would you see me doing, right? And so this is where we talk about what people do. And this might be arguing with a loved one, or within the context of a hospital stay, feeling, you know, if you're feeling angry about something, you might find yourself being short and abrupt with a caregiver. You might find yourself isolating yourself. You might distract yourself with your phone. This is where drug and alcohol use might show up. This is where things like rage cleaning show up. A lot of my nurse colleagues do a lot of rage cleaning. This is where things that sound kind of, you know, benign, like exercise, might show up. Netflix is definitely something that shows up a lot in quadrant 3. And it's really important within the context of this model to understand that nothing is good or bad. We're just looking at it from a functional perspective. What is it doing for people? Is it working to move us toward what's important, or is it working to move us away? And so we try and notice this without judgment. And the other thing we might notice when we're exploring this is that, so we might have a feeling. So let's say I'm feeling guilt, and then I might go and distract myself maybe with some emotional eating, eat something really delicious, but then that might bring up a feeling of shame. And then I might try and distract myself from that with, you know, playing games on my phone. And then I might feel really foolish and stupid and physically shut down because of that. And then I might get irritable with somebody. So what I'm illustrating here is the way that for most of us as human beings, we spend a lot of time spinning between 2 and 3, between having feelings and distracting ourselves from our feelings, and then having feelings about that and distracting ourselves again. And that's a really fruitful area of discussion with NICU families, because, you know, a lot of shame can come up about this. Oh my goodness, I've just wasted a whole day, or I could have been with my baby, but instead I was doing X. And what we try and do is create just a space of grace for ourselves to just recognize, to just notice what we're doing, and then hit the pause button. And hitting the pause button can look like a lot of different things. It can look like taking deep breaths. It can look like going on a little walk. But what it does, it gives us a little bit of space around all these painful thoughts and feelings. And into that space, we can invite a choice. And that choice can be to do something that connects us to something that's important to us. So for our families, and we talk about it being a bold move. We ask families to make a promise to themselves of doing a bold move within the next week or 2 weeks. And what this ends up looking like is not necessarily a big move. It could be something like having a coffee date with a partner. It could be calling an old friend. It could be doing some exercise. What all these moves have in common is that they're very meaningful to the person who's making that commitment to themselves. It's something that's achievable. It's something that feels like forward movement. I, from outside their experience, don't get to tell them whether it's meaningful or not. They're the ones who get to decide. And it's really beautiful to see what happens once people make this commitment to themselves. And we say that we'll follow up with them about it, not in sense of like, chiding them or nagging them, but out of real curiosity to see what happened. Did anything get in the way? But what I've noticed is what happens is that once people are able to take a step towards something that's meaningful, doesn't make any of the painful stuff go away, but it makes them feel a little bit like they have some control, some power in their own lives. And that is a wonderful kind of counterbalance to everything else that they're experiencing. Now, another model that I've been using a lot with NICU families within the context of this work, and also with, I run a support group for the Canadian Premature Babies Foundation, and we talk a lot about this kind of stuff there as well, is that in addition to everything I just talked about, there are some sort of pillars, there's some foundational pieces that are really important, and that I really encourage anyone who's working with NICU families, whether they're in the unit, whether they're at home, it's really good to talk about these building blocks for wellness, for well-being, and those being sleep, movement, food, and connection. So at a time like this, COVID, so many things are shut down. It's so difficult to do anything. And sometimes we do kind of have to go back to basics. And so these basics are, are you getting a good night's sleep? And good, I put in quotation marks, because lots of people with new babies and small babies at home are not getting this mystical 8 hours that people talk about. But are you getting enough sleep that you can survive on it? And if not, let's talk about a strategy that's workable for you in terms of how you're going to get that sleep. But let's have explicit conversations with people about sleep. And movement, it doesn't need to be training for a marathon. It needs to be, how is your body? Are you getting opportunities to move throughout the day? Are you getting outside when it's safe to do so? Is there any type of exercise you can invite into your life? Any amount at all? And are you getting an opportunity to move every day? And to gently, with curiosity and no judgment, check in with people about this, because again, it's really, really important. Food/nutrition, also really, really important. It can be such a busy family, a worried family, it's hard to make time for good meals. So coming up with a workable strategy, how are people going to get fed, and how is it going to be decent food for them? This is something that it's really great to spend some time working on this kind of plan with a family. And the last one is connection. And I think, everyone today has sort of talked about this, that it's so lonely being an NICU family sometimes. You feel like your experience is so different from everyone else's. You feel so alone in it. And right now, all those opportunities for connection so many of them are closed to you. You might not have felt safe anyway going to a baby group, but they aren't even running right now. So how do we work on connecting with people? How do we get that little bit of connection every day with somebody, whether it's somebody living with us in our own house, whether it's a neighbor, whether it's online, whether it's via Zoom, it doesn't really matter. But we need to have conversations. We need to stay in connection. And so I think that if at times when everything else seems impossible, focusing in on these foundational pieces with families, those are great areas for exploration to kind of find those bold move opportunities, to find like, where is there a possibility for movement for you? It's okay if you try it and it doesn't work. It's the trying, it's the experimenting with it that can feel very, very empowering. And just a couple more minutes just to say, if you want to learn more about our study, There's some great material online. The team has put together so many fabulous resources for families. And if you want to learn more about ACT, which for me has been so transformative, these are a couple of books by Russ Harris. He also does a ton of stuff online. And so if you Google him, you'll find fantastic content. But these two books, ACT Made Simple, more from a clinician's point of view, and The Happiness Trap, which is a great sort of, such a readable book. And there's actually a really visual version as well that's wonderful. And I would so heartily recommend them. And I think that's our time. And so would just love to open it up for questions now.
Wonderful. Here's my time to poke the audience for any questions. We've got a couple here that I will share with you now, and just other folks go ahead and ask away. So Jamie asks, what can we do to support face-to-face interaction or stimulation between infants, family members, and care providers in the NICU and leading up to the transition to home? And he or she qualifies. I'm not sure, Jamie, if you're a boy or a girl. The care team providers are growing more and more concerned about facial expressions reading and experiences for prolonged stays. Anyone?
One thing, and obviously I'm not speaking as a clinician here, but something really interesting that a partner hospital in the United States is working on is they have masks with windows in them. And as babies are getting older and getting ready for discharge, parents have been using those masks so that babies can actually see their faces. Because I agree with you, I think it's a really interesting issue. Everything's so new that we don't really, there's no data, but from a common sense point of view, yes, I think it could be a real problem. So I think that this is sort of an opportunity and a moment for exploring some of those sort of technological solutions. Can we figure out what's a safe way of making it possible for babies to see their mom and dad's faces? So I'm really curious to see how this test with the see-through masks goes. I think they just started last week. So if I hear anything about it, I'll share that.
Fabulous.
I know in our NICU, parents do not need to mask. We have individual rooms, and so staff all mask. But when parents are in the rooms, they don't need to.
I think it's interesting because, there's been a lot of back and forth data on the individual rooms and the pros and the cons of it. And certainly the pandemic is a heavy leaner towards the pro of private rooms. It does allow social distancing. It does allow more opportunities for babies to not have their parents be masked the whole time. I think the other key thing is that babies' vision probably, certainly early on, I'm not so sure that the mask, when they're really, really small and they're there for a long time, there's going to be some period of time where that isn't necessarily going to be the most relevant thing to them, because I'm not so sure that they can appreciate or take in that degree of detail at a distance as well. And as they do start to become more aware of it, as they get further along in their gestation, that's where the benefit of a private room would be arguable, that they could then have a moment without their mask with their parents. And I think, like Kate has said, the clear masks is a really cool option as well. Also being looked at for different populations from autism and from hearing impairment. So it has legs beyond just the NICU of people being interested in it.
Absolutely. Even outside of the healthcare setting, some folks are quite interested. Another question from Natasha. Given that many of our NICU staff are also feeling the impacts of the COVID pandemic, inevitably it is impacting their role in the NICU supporting patients and families. How can we ensure our providers are aware of this and support them to best support our patients?
I think that's a really good question, because I know, I have two roles. It's a me speaking. I have my woundostomy role at BC Children's, and then I've also got the nurse navigator role. And I know from both my roles that I've been finding that families have been emailing or having questions about things that I thought were really basic. I was surprised that people were coming up with these questions that seemed not important, but that I know that that's not the case. And I realized that actually my office mates were also finding that families we were having more phone calls about topics or subjects that families would have problem solved easily before. And I think we were all starting to feel annoyed at these silly, what we perceived as silly questions. And all of a sudden we've all stopped and looked at each other and we're like, oh my gosh, this is the pandemic. Like, this is that layering piece where families are having added layers of stress and are not able to cope. We are also having the same added or similar added layers of stress and getting more easily annoyed. And I think once we all sort of stopped and recognized what we were feeling, it made it a bit easier to take a step back and give parents more space to be needier during this time. And I think it is important for staff to realize that they may notice that they are becoming more frustrated and having some of these emotional responses, in large part due to the added stress. I don't think there's not an easy answer to fix it, though.
Well, yeah, I just love what you said there, and I think it's Kate here. I think it's not fixable, but this is exactly the kind of thing that that ACT was designed for. About how do we live with it, right? And I feel like what you're saying is, like, if we can all notice and just remember that for everybody, our kind of our zone of tolerance, like what we can kind of take and process in an ordinary day, it's whisper thin for everybody, right? Mm-hmm. And so if you're working in a hospital and you're going in there every day and there's that little bit of anxiety when you're going in all masked up, am I going to be safe? Am I going to leave this hospital safe? Am I going to bring anything back for my family? That's a huge burden that you've been carrying for a long time. And it's going to have an impact on you. It's going to give you a little less wiggle room than you might usually have, right? So I feel like it's so important for us all, people who work, caregivers, clinicians, families, for everybody to have opportunities to talk about it, to not try and fix it. We have to live with it, but how do we give ourselves space where we can kind of explore these feelings and recognize, how is this showing up in my behavior with other people? Are there other things that I can do with this? Because it's not reasonable for us to expect that we would live through a pandemic like this, that none of us have experienced anything like this in our lifetime. It's not reasonable for us to think that it's not going to have an impact on us. It's absolutely going to show up. And all we need to do is slow down and pay attention, I think.
Well, and I think there's so many variables that are not able to be controlled, that if you're the point person, it's a lot easier for people to reach out and even to become angry and frustrated with you as that end care provider, because you're tactile, you're something that they can reach and touch, as opposed to all these other nebulous pieces that are really out of their hands.
Yeah.
What are the opportunities to leverage virtual care, but other different ways of doing things to provide the kind of support for both families and for staff, likely separately, but perhaps sometimes together, like things like family participation in virtual rounds or online support for families? What have you seen that has worked through this?
Well, I'll say something, and then I'm totally going to put Paige in the spot because she's been doing so many interesting things online. But we've been running, so with the Canadian Premature Babies Foundation and at Sunnybrook, we've been running weekly support groups for families, and they've been lovely. Again, this sort of focus on creating a safe container for people where they can explore what's going on for them. There's a little bit of problem solving, but mostly it's about giving people space for those feelings. And Zoom can be a fantastic medium for that. So it's one of those weird things where it's a little like, what Amy was talking about earlier, that there's a little bit of silver lining with this, is that we've realized there are a lot of things that can be done virtually and that we might well continue to do virtually even after the pandemic's over. Because for a lot of families, like, it's not always possible to do in-person things. They're very busy. They don't, want to schlep their kids around, but it can work really well online.
Makes sense.
Yeah.
In terms of the health inequities that COVID has revealed, not just for kids in NICU, but you've referred to, in particular, a public-private physiotherapy options as examples, but not everybody necessarily can afford that. What are you doing, or can we all support in advocating for to help reduce those inequities?
I think this is Paige speaking. There's a great quote, and I believe it's from Churchill: "Out of crisis comes opportunity." And I think as a healthcare provider, while I am far from amused to be in the pandemic and find it incredibly frustrating, it's also been a huge opportunity. I grew up in a rural area in Vermont and commuted to Boston for my healthcare, and that is expensive, and it's time consuming, and it was stressful. What I'm hoping will come out of this pandemic is a much stronger network for families to link to healthcare providers that they need without having to experience that kind of stress and cost, because we can Zoom in and do visits. And while sometimes we're hearing from families that it's not quite what they would have wanted and they would rather be seen in person, it's a choice. And the choice didn't exist very easily for any families or for us as providers before that. So I think there are opportunities to actually make healthcare more accessible with the virtual aspects, and I hope that that's what we're going to see, and that then does address some of the inequity that we see with how healthcare is provided.
Absolutely.
Yeah.
Go ahead.
I was going to say, I have to agree with Dr. Church. I think that has been huge. In BC, we have, well, I guess same with Ontario, anywhere in Canada, there's lots of rural areas, and that has increased accessibility for some families for sure. I think the challenge is that for families who were hoping to get hands-on service, I think that's something that is worth problem solving, to try and get more face-to-face time in some of the publicly funded systems for things like physio and occupational therapy, because that's been a big loss, I think, for families. So pros and cons.
Absolutely. And I imagine that the wait list for such services is also increasing, much like it has for a lot of other community-based services as well.
Yeah, and this is Paige again. I'm hoping that as we experience this new wave, that the idea of just closing because COVID's here, I mean, that was acceptable in March. I'd say it's unacceptable now, and agencies need to learn to pivot and be accessible, because the wait lists are long, and they are long partly because everybody was caught off guard, but that's inexcusable now. We know what we're dealing with. We have a better sense of what the virus does, how it's transmitted, and what we can do to still provide care. So I'm hoping that across the country, across many disciplines, we're going to see a greater sense of pivoting and just getting back into the work and just getting it back to work, because we can't just pretend that these problems aren't there, and we can't just accept that we can just wait, because we can't. So creative ways to diagnose autism, creative ways to diagnose cerebral palsy, creative ways to provide therapy, it all needs to be fleshed out.
Absolutely, and you're getting a lot of support in the chat box for your comments, Dr. Church. There are no more questions, so I will take this time to thank you so very much, Paige, Amy, Ami, and Kate, for sharing your time, expertise, and stories with us today. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization, and some incentive to help make change where you work. We have a packed fall Spark Live webinar schedule tomorrow on September 30th during our regular Spark Live time slot at 11 Eastern. We will hear about championing pain within your organization in a time of COVID. And next week on October 7th at 11 a.m. Eastern, we will host Net Worth of Networks, a quality improvement tale. As well, registration is now open for our annual conference, which is taking place virtually from November 16th to 20th. Visit our website to register. It's always great if you can watch live, as your questions and comments enrich the discussion, but if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So look for the notice in your inbox, and they should be there in a week. So thank you again for joining us today. Thanks to Paige, Ami, and Kate for presenting, and to Childbright for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.